This is the Shelbourne Knee Center podcast, and we have Dr. Marc Haro with us again. He was here with us last week to talk about lateral side knee injuries during multi-ligament knee injury repairs and reconstructions, and we had a nice discussion about that. And Marc joins us again. Marc, thanks for coming back for another one of our weekly podcasts.
Yeah, thanks for having me.
Tonight's topic is going to be another study that Dr. Haro worked on with Dr. Shelbourne back in 2009. This study was published in the American Journal of Sports Medicine, and the title is Incidence of Subsequent Injury to Either Knee Within 5 Years After Anterior Cruciate Ligament Reconstruction with Patella Tendon Autograft. So an interesting topic, which is always a fun one to discuss, what to do when these patients re-injure, how often it happens, and what can we identify that may predispose them or make it more likely that they could tear.
Yeah, so this is always a great topic, and I think for, orthopedic surgeons, physical therapists, athletic trainers, really anybody treating patients that have an ACL reconstruction. And one of the biggest topics that, we hear about at meetings or different office conversations is what is the incidence of subsequent injury, mainly to the reconstructed knee, but also to that contralateral knee, and what factors lead to that. So I guess right off the bat here, Dr. Haro, what was the rationale to conduct this study looking at incidence rates of re-tears and opposite knee tears after ACL surgery?
I think that's really what the impetus of the study was people coming in and saying, like, what's the likelihood that I'm going to do this again? Or what's the likelihood that I'm going to do it to the other side? And, pretty much every patient has that question. And, we really didn't have good ways to answer it back then. There was a couple smaller studies that were starting to look at it that, didn't break down patients as we were seeing them, and it was just kind of all comers coming in, and which is really saying no difference, which wasn't exactly what we were seeing. We were seeing that maybe young females were having a little bit higher incidence of tears to the other side, and so just really wanted to answer some of those questions that would pop up at meetings, or whether it was from patients or other therapists, and so that was really the purpose of that study.
Now that leads to the next question is, what was the hypothesis for the study? And did you get that from previous literature, or was that something you were questioning after seeing these patients in the office?
It was probably after what we were seeing in the office, and maybe some other papers, and what we felt was maybe lacking from other papers. Like, it was a little bit different than what we were seeing. We were seeing the differences where everybody was saying there was no differences. We were seeing differences, but in subsects of population. So it was more to try and break it down a little bit more in detail, so we give a little bit better, targeted advice, as opposed to a blanket statement. Everybody has the same risk, to either side, which was really what the literature had shown at that point.
So let's jump right into this paper. Tell us a little bit about the methodology behind this paper and how the study was conducted.
Yes, this was a cohort study where we had kind of followed ACL reconstruction patients that had been done at the Shelbourne Knee Center for 5 years, and really looking at the risk of injury to their ACL leg or a contralateral leg, and whether or not certain factors played into it, such as their age, their activity level, when they returned to sports, because that was the big question. There was a dogma at the time of 6 months. After 6 months, you were safer than you were before 6 months, which was a little bit different. So we really wanted to look at all these factors, whether it was, activity level, age, re-tears. And, we definitely, looked at 1,800 patients, or actually at 1,800, we had 5-year follow-up on 78% of them. And, that's kind of the factors that we were looking at.
Yeah, with a large database like Dr. Shelbourne's been able to maintain over the last 4 decades, it's really something to be able to do a study like this and not get 100 people, to be able to look and get almost 2,000 patients,
right?
And get information on the majority of them is really striking, and I think a real strength of this manuscript.
Yeah, I agree. We had, even studies today that, cite this, there'll be big meta-analysis and studies. We're looking at risk of re-tears, and, big multi-center study groups will have less than we find from our database. So, some of these papers, this study's 80% of the patients that they have, It's such a large study, and he was able to track them, and still is to track them for quite some time with tremendous amounts of data, from physical exams to, subjective questionnaires.
That's something I was going to mention. I think I might have read that same systematic review and meta-analysis where you read the abstract and you think, wow, those results look really similar. And then you read deep down, and 80% of the patients that they were using were from this paper.
Yeah.
Yeah. So what were the factors then, Marc, that you looked at with this study, with that large patient cohort? What were the factors you were really looking at to try to discern whether there was a difference?
there's a lot to take out of this study. It was a pretty big, complicated paper just because there's lots of data that we were looking at. We were looking at, gender. Was there a difference between males and females? We were looking at age, and then if age, what age is, and we broke them down into essentially three groups. The under 18-year-old, like high school kids, and then kind of the more college age young adults, the 18 to 25-year-olds, and then those of us who had kind of moved on and had real jobs and were a little bit busier, and the 25 and older crowd. So we looked at the ages, we looked at the genders, we looked at whether they tore the same leg or the contralateral leg, and then we looked at whether they returned to sports less than 6 months or greater than 6 months. And then we looked at, activity levels and how these all correlated, and to try to figure out, if they were tearing or re-tearing or tearing the other side, what factors were involved.
So knowing those were the variables that you were looking at, what were the results that you found?
Yeah, like every other study, if you looked at, everybody kind of like all comers, all patients, regardless of age, gender, we were seeing that, people are about just as likely to re-tear their, graft as they were to tear the contralateral side. But as we started to break it down, we saw pretty distinct differences when it came to like gender. We were seeing that females were twice as likely to tear the contralateral side as they were to tear their, graft again. Where interesting enough, males were about just as likely to re-tear as to tear the other side. We also saw that, age definitely played a role. As you got a little bit older, you probably didn't partake in the same, risky sports you were taking in as you were in a high school kid. And so the re-tear rates dropped dramatically with kind of each age group, especially when you got to the over the 25-year-old group. And we also didn't find, which a lot of people were worried about, was that those who went back less than 6 months, they weren't re-tearing at any higher rates than if they went back after 6 months. So those are kind of the big take homes, I think, that we found from our study.
Yeah, I think it's fascinating to look at those numbers just with all comers. I always kind of, when we had this, discussion with people, when people ask about this, I always have that discussion of that 5.3%, 4.3% are numbers that I have committed to memory specifically from this paper. When people say, what's the chance of me doing this again? It's a 5.3% chance of tearing the opposite ACL, a 4.3% chance of tearing the same ACL. And sometimes people hear that and they're like, oh, okay, well, 10%. Okay. Well, not so fast. Then we have to start thinking about, am I dealing with a male patient or a female patient? Am I dealing with a young patient or an old patient? Am I dealing with somebody who plays no sports, who plays recreational sports, somebody who plays competitive sports? And whether or not it was before or after 6 months, I think is always an interesting one as well. So those take-home points, one of the main ones was that females had a higher incidence of contralateral tears and a little bit lower incidence of re-tears, as opposed to males had more of about the same risk of re-tears versus contralateral tears. So a lot of factors at play there. What was your proposed explanation? What do you postulate is the reason for those phenomena?
Yeah, so everybody was getting the same size graft. Everybody was getting a patellar tendon graft, which is a little bit different than some of the other studies where there was ACLs with hamstrings or patellar tendons. We were doing 10 millimeter patellar tendon grafts in everybody, and so post-surgery, that was one of the bigger, things that we saw, is that, previous studies had shown that females had smaller ACLs than guys. But once we put everybody on the same, level, when everybody had a 10 millimeter graft, what was happening? Well, women were tearing the smaller ACL, or guys were tearing either one at equal rates. So it really seemed that size made a difference. The size of the ligament that we were putting in there made a difference. We were putting in a bigger ACL in females than they had natively. So when they'd go back to sports at high levels and had an awkward landing, the contralateral leg was tearing at a higher rate because it had a smaller ACL.
And people ask that sometimes, like, is this new graft that you're going to put in there, is this ACL going to be stronger than my current one? It's going to be better than my other one, isn't it?
Yeah.
I always think that's interesting when I hear that about ulnar collateral ligament reconstructions as well. It's going to make my elbow stronger, right? I'm going to be able to throw harder with this one, aren't I? That's a whole nother discussion. But specifically to ACL reconstructions for females, we could say, yeah, it is going to be bigger than the ACL that you had before. And because of that, you're probably more likely to tear your opposite one than you are the same one. Whereas males, of course, there's variability associated with that, but a 10 millimeter graft wasn't that much bigger, if at all, than their native ACL was. Especially if they had larger notch that we measured on plain radiographs, and I think that was where Dr. Shelbourne started noticing the difference between males and females. The age part of it, of course, plays a big role as well. As you said in this study, that for people under 18 years old, the risk of subsequent injury to either knee was 17%. So when people hear that 9.6% combined with all comers, then you get to below 18, though, it goes up to 17%, 18 to 25-year-olds, 7%, over 25 years old, 4%. So there's a wide difference with age. And talk a little bit about what factors are at play there with the age discrepancy.
Yeah, I mean, I think a lot of it's just the year-round high-level sports that kids are doing. When you're under the age of 18, it's just, constant, whether it's, summer ball, fall ball, winter ball, spring ball. So I think that's kind of the biggest thing. And, that middle age group is kind of a little bit in between, because especially with his patient population, there was a lot of like high-level college athletics in there, but there's also, the kid that was playing at the co-rec and, landed awkwardly and tore their ACL as well, but they weren't going back to like D1 football, So I think there's a little bit in that age range, but, universally, unless you're professional athletes, those over the age of 25 were, they had 9-to-5 jobs, they're weekend warriors and stuff. So the exposure rates definitely went down. So I think that's one of the bigger reasons why you see those significant differences in the age groups.
Now, one of the points of this paper that I really thought was fascinating was the fact that you found no difference in injury rates for patients that returned before 6 months and after 6 months after surgery. And we just had a paper published that was looking at contralateral outcomes just a couple of years ago, and our average time to get back to sport was under 6 months. And, taking the patients from this database, a lot of times that is the case, whether we're talking to students at a school or talking to others presenting at national conferences and things. That's usually one thing that shocks people, and a hand shoots right up in the audience and says, are you really getting patients back that early? And I confidently answer that as yes. And a lot of times I refer to this paper. Can you speak a little bit about that result and what you may think about that?
Yeah, I mean, I think a lot of it has to do with the rehabilitation. I mean, I think it's just a different philosophy on the rehabilitation, and more being, let's say, criteria based versus time based. Again, there was this magic 6 months that, I remember when I was a resident, 6 months, like, okay, now it's time to go back to sports, and you're like, wait a minute, like what changed between 5 months and 30 days to now 6 months, and magically I'm cured? And I think that the accelerated type rehabilitation, where we're really pushing symmetry early, people are getting back to like strengthening and more dynamic activities earlier. Their strength's coming back earlier, their emotions coming back earlier, and they're feeling more normal at that point. And it's almost like hard to slow them down. They look normal, and I have a hard time trying to convince them. And again, it's probably more for me to convince myself for some reason that I feel like they should go slower, but they're checking all the boxes off early. And it's, once they check those boxes, I don't have a really great explanation for them why they can't go back early. I don't know if that's how you guys are feeling.
Yeah, and I'm glad you said that. I just recently looked at that Panther Symposium consensus statement on return to sport, and the thought was to get away from time-based. Yet when we say that our athletes are getting back at a certain time, we always get a lot of questions, and we feel the same way with having everything be criteria-based and returning athletes back to sports and really getting away from that time-based.
Yeah, and again, there's been obviously some papers published by certain individuals that they're pushing this 9 month to 2 year type of philosophy, not return to sports for 2 years, which just seems insane. I think what's the point of doing these reconstructions for a lot of these kids then, if we're not letting them go back to a year or 2 years, and then we're automatically taking them from that high risk group and putting them into the low risk group. So are your results any better by delaying this, or are you just taking away their activity? So I'm a little skeptical of some of those other studies that say that we have to wait, especially when we have pretty good data saying that we can push them, and when their knee declares that they're ready, we can let them back.
Yeah, I'm with you on that. I think a lot of the longer return to play criteria, the time-based criteria, you have to wait until that that ligament looks more normal on MRI scan or whatever, that leads you to a year return to play or 2-year return to play. I think you're taking that 16-year-old athlete and you're making them an 18 or 19-year-old athlete, 17, and you're giving them 2 years later, and all of a sudden they're into that group that naturally does have less of a chance of re-tear. I would also argue that, of course, there's no doubt about it that people are more likely to re-injure their ACL either on the same knee or the opposite knee within the first 2 years after they go back to sport. I don't dispute that one bit. My contention would be if you restrict somebody for years 1 and year 2 after return, then their biggest years that they're going to have a chance to tear their ACL are going to be years 3 and 4. If you restrict them for 2 years, the first 2 years after they go back are going to be the most likely ones for them to hurt themselves. If you were to restrict them for 4 years, their most probable time of tearing their ACL would be years 5 and 6. I just think that whenever you get back to playing sports, if you get back at a high level, that's when your exposure is going to be the highest, your competition is going to be the highest, and because of that, your tear rates are going to be the highest. Another different way to look at this that isn't looked at in this paper, but it's one that we talk about at Shelbourne Knee Center quite a lot, is the side that you take the ACL graft from. And I think that's where, when Dr. Shelbourne started looking at these things and started assessing all these factors, that he started noticing some differences, and that he started to see, to maybe think about this in a different way. In particular, he noticed when he was doing same side ACL grafts, ipsilateral ACL patella tendon reconstructions, that people were much more likely to tear the opposite knee than they were to tear his reconstruction. And he, like most people, I think that do ipsilaterals, were happy about that, well, they're not tearing my graft, they're tearing the other one, which I can't do anything about. So when he started to, because of the rehab advantages that the contralateral potentially has, which you can listen to our earlier episodes about that, as to that rationale, he started seeing more re-tears as opposed to contralateral knee tears. And I think that was a place where he really stepped back and said, well, is the place I'm taking the graft from making it more likely to re-tear? Or are there other factors at play that are making it more likely to re-tear? And that's where he started breaking it down: males versus females, age differences, strength differences, intercondylar notch width, ACL size differences, and it's come to the place we are now, where what we found, I think, when we put all this data together, from notch size, from athletic exposure, from age, from gender, from sport, all these together, is that we don't really change anything about the tear rates depending on which side we take the graft from. The only thing we influence is which side re-tears. Now, it's not the amount of tears, but does have a little bit of an impact on which side re-tears. And we've particularly found high tear rates on the contralateral knee in young females who go back to play high-risk sports like basketball and soccer and have a small notch that have a graft taken from the opposite side, or from the same side. So if you do an ipsilateral patella tendon graft ACL reconstruction on a young athlete playing a high-risk sport and they have a small notch on their other side, we found tear rates up to about 20% even for that opposite knee, versus when we started taking the graft from the opposite knee, those started to even out a little more. Still was more of a propensity for the contralateral knee, but it didn't influence how often one of the two knees tore. It just influenced which knee tore. And I know in Don's experience, it was seemingly a much more devastating thing for the athlete to re-tear the same ACL again than it was to tear the opposite one. So just wanted to hear, I did a lot of talking there, but I just want to hear your comments on all those different factors when we start to take the side that you take the graft from into play.
Yeah, no, I mean, I've seen that as well too, and I've talked to Don about that before, and he thinks that taking the graft obviously from the contralateral side almost weakens that one temporarily, and during the rehabilitation process is almost a little bit protective of that leg, which is a little bit counterintuitive for a lot of the current, like, all we care about is quad strengthening, but a strong quadriceps probably can lead to some of this, the mechanism of an ACL tear. And if you're a little bit weaker, a little bit more protective of that leg, it probably lowers that incidence and probably protects that knee a little bit. So yeah, no, I think taking the graft from the contralateral side probably does influence the side, but I think once you get back, there's still risk. So
yeah. Mark, do you do any contralaterals or not? I wasn't.
I probably don't do as many as Don wants me to do, but I probably say as many as I can talk into the high level athletes. I'm I'm on an island out here in South Carolina doing contralateral grafts, but especially in kind of young athletes who are trying to get back in a accelerated rate and have a chance to kind of compete again, I definitely offer the contralateral graft.
Yeah.
And it scares a lot of therapists around town. I don't have necessarily quite in-house physical therapy. I have definitely a group of physical therapists I work with pretty closely, but it scares therapists. They don't know what to do. They don't know you can go fast, and then they really freak out when at 3 weeks the athlete's like, I feel normal. Can I go back to to the gym? And you're like, no. But it freaks them out because it really breaks up that rehab, and I think you can really go pretty fast. So I would do more if I could probably talk more into people at around here.
Yeah, discussion for another day, and we've already done on this podcast once already, so we won't really rehash that too much. We'll point people to our series on contralateral grafts for ACL reconstruction. But interesting part of this debate as we talk about incidents of tears. There seems to be a sport predilection for this as well, and of course that matters as well. So talk a little bit about, do you change the discussion that you have with patients based on the sport that they're trying to get back to? Does that influence your speed of return to play, and do you believe that has an impact on when you have that discussion with them? Doc, this was really hard. I can't believe I had to go through all this. I'm ready to go back to play. What's the chance this has going to happen again as it relates to sport?
Yeah, I mean, the specific sports, I think maybe soccer is maybe a little bit more, difficult. At least I've found to kind of get back to sports at kind of that high rate. And I do worry about, soccer players a little bit. But I don't necessarily know if I change a whole lot. I think once the knee is ready, the knee is ready. And I don't necessarily slow them down any particular way. I think if they're checking all my boxes, if I'm going to be objective about this and have my boxes checked, once they check the boxes, we start pushing back. So I don't know. Are you guys changing sports or slowing people down for certain sports at all?
No, I agree with you there. I guess I wouldn't say I necessarily slow people down. I will be a little bit tighter with the criteria for return to play if they're going back to a high risk sport. If I have somebody that's a swimmer and they're, and I know that's an extreme case, of course, but if I have somebody that's a swimmer and they're, still 30% off on strength and their swim season starts, it may hurt a little bit more, but go for it. I think that's going to be okay. If I have somebody that plays softball or baseball that says, I start my senior year in another 5 months, do you think it's reasonable for me to get back and play? Baseball and softball is not a super high risk re-injury sport, especially, if I ask them, they say, oh, I'm a designated hitter and I play first base, and, okay, we can probably push it pretty quickly versus if they say I'm a middle infielder, I'm a pitcher, and this is my leg that I lead with, that I jump out on every time. Softball in particular, lead leg injuries in softball. I know there's been some studies about that, just the difficulty with that. To be honest, that I didn't even know about, and had some experience with those patients struggling a little bit that maybe slowed them down. But in general, I guess it's another factor that I'll keep in mind when we're talking about re-injury and return to play, specifically with basketball and soccer, because those do seem to be the highest risk ones that, if somebody wants to get back early, sometimes if they're a 15% side to side difference and, still feeling a little sore, not 100% sure if they can go back, but it's only been 4 or 5 months, but I want to get back and play my senior season. You know what? It probably makes a little more sense for us to make sure you're really symmetric, take a little more time, get you symmetric to make sure we don't end up with a problem with re-injury versus if they were playing a lower risk sport.
I had that exact same conversation today, actually, a contralateral patient. He's 5 months out, and he was high school quarterback. He was the team quarterback last year and also a high level track athlete, and probably actually getting D1 offers for track and field, and that's probably his big sport. But he does a little bit of everything. He also swims for the team, and really unbeknownst to me, he was feeling so good, he started swimming for the team this fall at 3 months. He was back fully swimming at 3 months, but getting a little bit of swelling at the time because he was pushing back so fast, and I had no idea really he was actually returned to full competition swimming at 3 months. And
I had a very similar experience with a kid wanting to get back to, I can't remember if it was soccer or softball, something like that. And, we're working through that. We get to the 3 month mark. How things been going with sport? Well, she's been swimming. She took up swimming this year. Oh, really? Is she swimming for her team? Yeah, she started her season a month ago at the 2 month mark, and she's doing really well. She's been competing. Oh, how about that? That's interesting information that I didn't know about.
They were asking me today if it was okay.
You're in the pool. You're not going to tear your ACL swimming.
Right. That's what I told him. He's like, he was really worried about this, and I was like, he's already qualified for states, as a swimmer, and I was like, yeah, you're probably safe. Just don't slip on the deck. I don't other than that, I think swimming's probably fine.
No running in the pool. That's the rules anyway, right?
Yeah, so, exactly.
Yeah, very good.
I think this discussion really illustrates how multifactorial this decision can be, because even, talk about the same sport or different sport, it matters to me what time of year it is. I have football players that want to get back for August, and it's April, and they say, hey, I'm a quarterback. Can I play 7-on-7? It's 4 months out of surgery. Sure, why not? And then they say you back 2 months later, and they're doing great. And they say, well, oh, by the way, I also played defensive back, and I was, playing defense as well. And, then it gets to the question of who clears who. A lot of times they clear themselves and based on how they feel.
Yep.
Yeah, I think in particular with it, that's something that gets more into art of medicine instead of science when it comes to taking care of athletes. That if it's one of us tears our ACL, we'll get back when we get back. Who cares when it happens? We want to get symmetric and normal as quickly as possible, and then progress at whatever speed you want to. But athletes under the gun saying they have a season coming up, sometimes that does affect our surgical decision making and whether we do a surgery or not, and what our timing is and what our return to play looks like and all that. So again, another discussion for another day. We've come up with a lot of further topics today. So Scott's probably scribbling furiously on writing down things for further episodes. So, well, Mark, thanks again for the last two podcasts being here with us, and we appreciate your expertise and time.
Absolutely. Happy to be here.
Thanks again for joining us on the Shelbourne Knee Center podcast. You can find us on our Facebook page, the Shelbourne Knee Center podcast Facebook page, or at the SKC podcast on Instagram and Twitter. You can find us on YouTube if you get your podcasts there, and wherever you get your podcasts, please drop a comment or a rating if you like what you've heard so far.